Okay, this is really, as promised, a very striking picture. This, looks like a mushroom cloud coming off of one of the Trinity um, atomic bomb test site, but no, it's a mushroom cloud, sure enough, but it's a mushroom cloud that's emanating from the surface of a cornea. And it's a cornea that's been struck by a single pulse from an excimer laser. And these are, this is the volatilized collagen monomers, all this sort of stuff that's coming off of the surface of the cornea, and it's forming this plume, this mushroom cloud. Now, here's what I want you to think about. I don't want you to think about the excimer pulse that has produced this mushroom cloud. What I want you to think about is the next laser pulse. So most of the next laser pulse, and these pulses are broad beams, most of the next laser pulse is going to pass through the cap of the mushroom, and sure, maybe it'll be a little bit obscured by that cap, and maybe the laser power that's reaching the cornea is diminished a little bit for having passed through this cap and scattered a little bit. Now, think about the portion of the laser beam that's going to be passing directly through the center of the mushroom cloud. It's going to have to pass through the entire stem of this mushroom, and it will be diminished significantly more than that portion of the laser beam that's passing through the cap. And as a result, it's going to ablate the underlying cornea in the area of the stem of this mushroom much less than the surrounding cornea. And the picture that we're going to wind up clinically, with which we're going to wind up clinically, is going to look like this, which is the slide that you saw right before this mushroom cloud, which is the island in the center of the cornea where the cornea is less ablated as it's passed through the stem of the mushroom cloud. Now, how do we deal with this? Currently, well, the most important way is that we have a little vacuum that's mounted, a little suction that's mounted very close to the patient's cornea, so that as the plumes come off of the surface of the cornea, they're immediately sucked up, and the laser beam doesn't have to pass through this sort of stem. You can also achieve an effect that's similar by decreasing the pulse frequency of the laser, giving the mushroom cloud a little bit more time to dissipate. Anyway, a little bit off topic, but interesting nonetheless. The reason that I bring this up is that island is in the hole in the bagel. That island is in an area that's not actually being measured when we do our topographies. And some of the topography units can have holes in the middle of their data gathering that are even larger than 1 millimeter. 1 millimeter of the central cornea, that's the most important part of the whole cornea. And we're not actually gathering data from there. Okay. I want to talk a little bit now about different ways that these topographic maps can be drawn, and then I want to discuss after that a little bit about what the problems are with topography generally. Anyway, the measurement that's actually taken of the cornea surface, and we're going to get back to this later, is radius of curvature. It's not really dioptric power. Dioptric power is a derived measurement. What we're really measuring is the radius of curvature at different parts of the cornea. And it sounds like that is only one measurement, but it turns out that it's not, and I'm going to show you why that is. So here we have a cornea that has a little defect on a little bump, maybe a Saltzman's nodule, that's on the right-hand side of this diagram here. And we're trying to find the best fit radius to map out this curve as opposed to the curve of the rest of the cornea. Now, we're putting a constraint on the radii here. We're constraining them to say the radius of curvature, that radius arm there, needs to originate along the visual axis of the patient. It has to be along the optical axis of the cornea. And you say, well, how else could it be? How else could we measure it? Well, I'm going to show you in a sec, but I want you to see in this diagram that all of our different radii of curvature on this cornea all originate on the corneal's optical axis. And you'll see that the approximations are influenced by this constraint. The other way of doing it is to say, well, we're not going to constrain where the radius of curvature, where sort of that fulcrum is. We are going to let it appear anywhere that it needs to in order to get the best fit curve. And this lets us match the curvature, in this case of the Saltzman's nodule, much more accurately than we did in our axial map, and I'll show you that once more. So once more, this is axial radius of curvature, where we're constraining the fulcra of the radii to fall along the patient's optical axis. And you can see that when it comes to the Saltzman's nodule, that we've drawn a circle that matches the curve of the Saltzman's nodule fairly poorly. And you may or may not get the gestalt too, that the radius of curvature measurements here are a little bit more spread out. And I'll show you later what I mean by that. But I certainly want you to see that the radius of curvature for the Saltzman's nodule, that the arc that it draws maps the shape of the Saltzman's nodule much more poorly than in a tangential radius of curvature scheme. Now, let's see how this matters clinically. This is a patient with keratoconus, and on the left-hand side, we see a topographic map that has been drawn using the axial radius of curvature scheme, and on the right-hand side, one that is the tangential radius of curvature scheme. And as we would expect from the previous diagrams that I showed you, the lesion, the cone, is a much more discrete, defined area drawn on the tangential map. And it's also much steeper drawn on the tangential map. Whereas on the axial map on the left, the cone looks much more spread out over the cornea. Tangential maps, like the one on the right, are very helpful for localizing lesions. Axial maps are very helpful for determining the influence that a lesion is going to have on the patient's vision, since the axial map describes what's going on along the optical axis of the cornea. The tangential map makes more discrete the actual lesion. So axial map and tangential map, we have to be able to recognize at what we are looking. Again, tangential map shows us the bounds of the lesion better. Axial map shows us what we expect to be the influence of the lesion on the patient's vision. Okay, once more, this is a comparison of an axial map to a tangential map, the effect clinically versus identifying the extent of an actual lesion. This is an Orbscan printout, and I want you to be able to recognize what it is and at what we are looking. There are 4 maps here, and the one on the lower left-hand corner is the one that we're used to seeing. It's a power map, a refractive map, a dioptric map of the cornea, and we recognize the familiar hourglass shape telling us that this is an astigmatic cornea with the rule. The upper left-hand corner map is an elevation map. So the one on the lower left-hand corner that we're used to seeing, that's a power map. That's a description of radii of curvature, the degree of curvature, the steepness of curvature in different parts of the cornea. Whereas the map on the upper left-hand corner is elevation. It's how high different parts of the cornea are. It's what the cornea looks like, what its shape is. And you say, this is the most useless thing that I've ever seen. Because if I want to see what the shape of the cornea is, I've got the patient right there. I've got a slit lamp. I can look at the shape of the cornea. Well, I wasn't being totally honest with you. The map on the upper left-hand corner is not a description literally of the shape of the cornea, but it is a description of the deviation of the shape from the closest fitting sphere, from the best fit sphere. So it's a description of only that component of the cornea that is non-spherical. Now let's ignore the periphery of this cornea here, because once more we have to factor in the peripheral flattening of the cornea that occurs near the limbus. Let's just look in the center and kind of paraxially in this cornea. And what do we see? We see our can of Schweppes bitter lemon lying at axis about 10. So we see the cylinder here. This resolves for us the cylinder. Of course, what we're interested in is the refractive effect of the cylinder. And again, that's shown in the lower left-hand corner. But the upper left-hand corner, that shows us the shape of the anterior cornea compared to a reference sphere. The upper right-hand corner shows us the shape of the posterior cornea. Now, our expectation is that there is a relationship that's relatively fixed between the curvature of the posterior cornea and the curvature of the anterior cornea. The posterior cornea being more curved than the anterior cornea, more steeply curved. How do I know that? How do I know that the posterior cornea is more steeply curved? Well, you know this clinically because you know that corneas, normal corneas, are thinner centrally and thicker as you head out towards the limbus. That means necessarily that the posterior cornea has to be more steeply curved than the anterior cornea. Think about that for a sec. We see the same sort of cylinder shape translated to the posterior cornea in the map in the upper right-hand corner. Once more, it's our beloved can of Schweppes bitter lemon, once more at about axis 10. The difference between the upper left-hand corner map, the anterior cornea, and the upper right-hand cornea map, the posterior cornea, is shown in the lower right-hand corner map. The anterior cornea minus the posterior cornea equals corneal thickness. So this is a map of pachymetry, optically derived pachymetry of the cornea. Now, the optical pachymetry is not one that I would, stake any important clinical thing on. If I were doing astigmatic keratotomy or radial keratotomy, I would not be setting my arcade blade based on a depth that I get from optical pachymetry. But an enormous advantage that this sort of optical pachymetric map gives us over ultrasound is that ultrasound can only give you a very limited number of points. Typically, clinically, we'll only do 1 point of thickness of the cornea, whereas the optical pachymetric map will give us a sense of the thickness of the whole cornea, and we'll be able to see areas that are thinner and areas that are thicker. This is a fairly normal-looking cornea, and you can see, by the way, that the pachymetry in the lower right-hand corner is pretty even, indicating that the cylindrical component of the posterior cornea must pretty closely match the cylindrical component of the anterior cornea, or we would be seeing some toricity in the pachymetric map on the lower right-hand corner. Interesting, no? Okay, before we get on to the next subject, which is going to be wavefront, I want to discuss an aspect of topography and indeed keratometry that is problematic for us if someone has had keratoablative surgery. And it has to do with the way that powers are determined when you've measured radius of curvature. Because keep in mind, all of these devices that are measuring the reflection from the cornea, whether it's keratometry or topography, are directly measuring radius of curvature and are then deriving from that the dioptric power at all these different points to produce our dioptric power map. Keep in mind, we're looking at this map, we're saying, this area is 46 diopters, this area is 42 diopters. But those are derived measurements. They're based on assumptions that are not always true, assumptions that certainly do break down if someone has had excimer laser surgery. I covered this in a lecture that I've given on intraocular lens calculation after keratorefractive surgery. What I'd like to do now is to play an excerpt from that lecture dealing with the way that keratometry and topography calculate power and what the problems are with this method. It's about a 20-minute segment, and then we'll pick up with our next topic here. So enjoy, and if you want to see more of it, there's a whole lecture on this topic with respect to intraocular lens calculations. I'll be happy to give you the link for that lecture.